So the CARTITUDE-2 study is a multi-cohort study where different populations of myeloma patients could be treated with Cilta-cel. And Cilta-cel is a BCMA targeting CAR T-cell product. It has two BCMA binding domains, and that confers high affinity binding to the tumor cell, and that may explain its high efficacy profile. In Cohort B, which was my topic at this ASCO, we enrolled patients with early relapse after autologous stem cell transplantation. And when the patient did not have autologous stem cell transplantation, the patient could be enrolled if he or she progressed within 12 months after initiation of first-line therapy. So we enrolled high-risk patients because early relapse means poor outcome, and typically patients that relapse within 12 months unfortunately die within 2 years. So this patient population in Cohort B really needs better therapy. So there's an unmet need, and that's why we evaluated the value of Cilta-cel in this patient population. We treated 19 patients in this cohort, 19 patients with early relapse. They received fludarabine and cyclophosphamide lymphodepletion therapy. Then they received Cilta-cel, and then they were receiving follow-up, but no other treatment. So the overall response rate in this high-risk population was 100%, including at least a VGPR in 95% and CR in 90%. So 90% complete remission in a high-risk patient population. And also important to state is that there were 15 patients that were evaluable for MRD negativity. And we looked at a very sensitive level MRD we look at the 10-5 level, and 14 of these 15 patients had MRD negative bone marrow, which is also an important finding because we know that MRD negativity translates into the best progression-free and overall survival in multiple myeloma. These deep responses translated into a progression-free survival at 12 months of 90%. And I think that's very encouraging because remember, all these patients relapsed or experienced treatment failure within 1 year. And now, after 1 year, we see that 90% of the patients were free of progression and alive. So that compares very favorably to the results that we obtained with first-line treatment in these high-risk patients. When we look at the safety profile of Cilta-cel, we always see cytokine release syndrome, like with other CAR T-cell products. In this cohort, it was always grade 1 or grade 2, except one patient that experienced grade 3 or higher cytokine release syndrome, but this was all manageable. There was also some neurotoxicity observed in the study. One patient had ICANS coinciding with cytokine release syndrome, and there was one patient experiencing movement and neurocognitive treatment emergent adverse event. And this patient had Parkinson-like symptomatology. But the most important thing to mention here is that this patient who developed Parkinsonism had multiple risk factors to develop Parkinsonism. He had a very high tumor load. He had progression during bridging therapy. He had massive CAR-T expansion. And also he had cytokine release syndrome. So multiple risk factors for Parkinsonism. The good thing is that this patient achieved a complete response, is still free of progression, and his neurology is still improving a bit. Now we know these risk factors for movement, neurocognitive treatment emergent events. Several mitigation strategies are implemented across the CARTITUDE program, and that has resulted in a marked drop in Parkinsonism from 6% in CARTITUDE-1 to less than 1% across the CARTITUDE program at this moment. And these mitigation strategies include aggressive, most effective debulking strategy, early treatment of cytokine release syndrome, and also adequate monitoring of the patient. And with that, the incidence of Parkinsonism has really profoundly decreased. And finally, in this study, we also looked at PD markers, we looked at cytokines, and as you may expect, high levels of IL-6 and interferon gamma were associated with more severe cytokine release syndrome. So overall, I think we can conclude that Cilta-cel was very effective in this high-risk population with early relapse, high response rates, promising PFS at 12 months of 90%, with a manageable toxicity profile.